He is board certified in obstetrics and gynecology and also in maternal fetal medicine. He currently is a professor in the Division of Maternal Fetal Medicine and is the director of the prenatal diagnosis program in that program. He received his undergraduate degree from Massachusetts Institute of Technology, his medical degree from Yale University, and he completed a residency at George Washington University Medical Center in Washington, D.C., and a fellowship in maternal fetal medicine from Georgetown University. He then completed a Diczfalusy Fellowship in prenatal diagnosis at King's College Hospital in London. His special interests have included prenatal diagnosis, clinical high-risk pregnancy, and prevention of obstetrical negligence. And it's really nice to have him with us today, and I look forward to his presentation. And you are on, Dr. Warsaw. Thank you.
Thank you very much, Dr. Archer. Thank you for that kind introduction. You can see the screen okay? You can see my slides?
Yes, but I need for you to speak up just a little bit more, please.
Okay. I hope you can see my slides, and I want to thank everybody in Hungary and Professor Ivan and everyone for inviting me and giving me this opportunity to speak on a subject that I've been interested in for a long time, and that is screening for aneuploidies. And this talk is really going to be about my 40 years of professional life in screening for aneuploidies and the journey that we have taken in this regards. And if I can leave everybody with one message, is what should we be doing in 2021? We should be offering cell-free DNA screening to all pregnant patients. And with that thought in mind, I'll now try to go over with you how I came to this conclusion. The objectives of this talk are first to cite the differences between a diagnostic and a screening test, to review the history of aneuploidy screening, my journey of prenatal diagnosis for the last 40 years, then to give us more detail about non-invasive prenatal testing, to show you the effect that NIPT has had on invasive procedures such as amniocentesis and CVS, and then finally putting it all together and to make it clearer as to how we should proceed moving forward. So to start off with, I want to make it clear what the difference is between a diagnostic and a screening test. A diagnostic test is designed to give you a definite answer, yes or no. Does my baby have Down syndrome or not? Typically, diagnostic tests tend to be expensive, invasive, and because of that, may have some risk to the pregnancy. And in the world of prenatal diagnosis, we're talking about amniocentesis, CVS, chordocentesis, those types of procedures. Whereas a screening test is not designed to give you a definitive answer. It's designed to determine if you are at risk of having a problem. Ideally, a screening test should be inexpensive, should have no risk to the patient, should be easy, reliable, voluntary, and to have an educational component to it. It's designed to pick a segment of the population that would benefit from a diagnostic test. Now, every screening test has a sensitivity or a detection rate, that is, the percent of the affected population that will be detected. Similarly, every screening test has a selection rate or a false positive rate, that is, the percentage of the population selected in order to achieve the sensitivity that we're talking about. And the efficiency of a screening test is the balance between the sensitivity and selection rate. So you want a screening test that has the highest possible sensitivity at the lowest selection rate. It's great to have a test that has a high sensitivity, but if the selection rate is 30, 40, 50%, then it's not a very good screening test. So the next slide shows you a few different screening tests, and I hope that we can all agree that the test that has the curve most left, which is the highest detection rate at the lowest false positive rate, would be the most effective screening test to do.
Excuse me, Steve. This is David Archer. Steve, could you speak up a little longer, and could all the guests please be sure they are on mute? we're having some problems with the audio. Thank you.
Uh, uh, so I think this is my speaker, so I'll talk right into it. I hope this is better.
That is
And
much better, Steve. Thank you.
great. Okay. And so, of course, what we're talking about is we're not screening for all chromosomal problems. We're talking about screening for the most common chromosomal problems in live-born babies. That is Down syndrome, or trisomy 21, Edwards syndrome, Patau syndrome. So these are the most common chromosomal problems that we see in live-born babies. Now, to start this journey, we'll start in 1984, and that was the year that I finished my training. And at that time, screening for Down syndrome was very easy. It involved asking two questions. How old are you, and do you have a family history of Down syndrome? And if you were age 35 or older at the time of your delivery, or if you had a family history of Down syndrome, then you were screened positive, and if not, screened negative. Well, although this was an easy and inexpensive screening test, it cost nothing just to ask two questions, it turns out it is not a very effective screening test. Why? Because most babies with Down syndrome are born to women under age 35, and only about 30 to 35% of Down babies born in this advanced maternal age population. And in regard to family history, the vast majority of babies with Down syndrome are born into families that have no history of Down. So a poor and ineffective, although inexpensive, way of screening for aneuploidies. Well, starting in the late 1980s, we began developing what we refer to as an individual risk assessment versus an age-specific risk assessment. So prior to this time, everybody age 35 had a Down syndrome risk of 1 in 270. Everybody at age 40 had a Down syndrome risk of 1 in 100. Everybody at age 23 had a Down syndrome risk of 1 in 1,000. But starting in the late 1980s, there was a recognition that pregnancies in which the fetus had Down syndrome had different levels of serum markers, particularly the alpha fetoprotein, beta HCG, unconjugated estriol, and that combined with maternal age gave us for the first time an individual risk assessment that some women age 35 had a higher risk of 1.27, some had a lower risk of 1 in 270. And in the early 1990s, a fourth marker was added, high levels of activin, and that developed the so-called quad screen or AFP4 screen, and there are many names for essentially the same test. And with this quad screen, we now were able to detect 75 to 80% of Down syndrome with a 5% selection. So our paradigm moving through the 1980s and mid-1990s in the United States involved maternal age and the quad screen, that any woman age 35 or older, okay, or any woman with an abnormal, who's under age 35 with an abnormal AFP, is screened positive. And with this paradigm, we were able to identify about 80% of babies with Down syndrome at an 18.5% selection. Now, how good was that? Well, let's look at this table here. Again, we saw this slide earlier comparing different screening tests. Now, with just by our history alone, we had about a 30% detection rate. That's down here, and about a 15% false positive rate. So we were here. But now we have an 80% detection rate, and yet to achieve that, we had to have an 18.5% false positive rate. So we were over here. We're moving in the right direction, but we ultimately want to get over here. So what was the effect of this new paradigm that went through the 1990s? So, well, before 1984, we were doing many invasive procedures, but few abnormal results. By the mid-1990s, we were doing many more invasive procedures, but still with few abnormal results. Then that brought us to the late 1990s, in which we recognized what we call first test screening, which which involved measurement of the nuchal translucency, that's the fluid-filled space behind the baby's neck. Here you can see a normal translucency. This would be an abnormal translucency. And combined with serum markers such as the beta-HCG and the PAP-A, that in the window of time of 10 to 14 weeks became a very effective and much earlier detection rate of Down syndrome. And this is the scientific basis for this nuchal translucency measurement. The measurement of about 21,000 cases, and that the euploid normal pregnancies, there was a very tight window of translucency measurement in a ground rump length time between 35 and 85 millimeters. So that would be 11. Whereas in fetuses with trisomy 21, you can see how most of them, the vast majority, had that were way outside the normal range. Now, there was a number of years at various conferences, there was shouting matches between the Americans advocating second trimester screening versus the Europeans who were advocating first trimester screening. But finally, in January 2007, probably 10 years after development, the American College of OBGYN finally recognized the effectiveness of first trimester screening as being comparable to second trimester screening, but even more importantly, that integrated screening, that is a combination of first and second trimester screening, is even more sensitive, and that all patients should be offered screening and diagnostic testing regardless of age. This is a big change here in the United States. Now, I don't need to go over all the different studies that were done that showed the comparison between different first screening. We've seen this slide before, and I just want to point out that this is the curve for the integrated screen, the combination of first and second trimester screening, and this was gold standard. Remember, we moved from down here to up here to over here. Now we're getting closer to our ultimate goal of getting this. Again, multiple studies that all pretty much show the same thing: 80 to 90% detection rate of Down syndrome screening. Of note, I think this was an interesting study that for every increase of nuchal translucency measurement by 1 millimeter, an increase in 1 millimeter, the risk of an abnormal karyotype odds ratio of 1.4. Anomaly 3, loss 1.7, abnormal outcome 1.9. Increase for every increase in millimeter. There were also many additional advantages of first trimester screening, and I think really what the important issue is that we moved all of prenatal diagnosis from 20 weeks down to 40, and whether that's in accurate date, identification of twins, identification of fetal genital abnormalities, this was a big push to bring earlier pregnancy, earlier diagnosis, earlier gestation. So this was a slide that I used for a number of years, looking at starting in 1975 when I did my first amniocentesis, and brings us on the journey to 2005, 2006, where integrated sequential gene screening, ultrasound markers, and all these things. And I always would end up the talk, this slide, talking about the future, that someday, hopefully, there would be a non-invasive prenatal testing test that had 100% sensitivity, less than 1% false positivity, and no risk to the patient. But I hope all of you understand that this is not the future. It's not even today. This is already 5 years past development. Now, there have always been two sources of fetal DNA in maternal blood. Even though one of the important physiological things that we all recognize in human mammalian reproduction is that the fetal maternal circulation should never mix, when in fact there's always been the recognition that a small number, 1 in a billion, cells in the bloodstream are fetal. But we never were able to really find or isolate those cells in a meaningful fashion to do any kind of genetic testing. But more recently, well, again, this is in the late 1990s, there was a recognition of cell-free DNA that could be identified in the maternal bloodstream. Fetal cell-free DNA is much more common than intact fetal cells. It's reliably detected after 7 weeks gestational age, has a short half-life, and so that you don't have to worry about the very low pregnancy next. And then through a technique called massively parallel shotgun sequencing of cell-free DNA, we were able to identify fetal fragments, fetal DNA fragments, and then line them up sequencing. And of course, it's only possible after the genome project, the entire human genome was sequenced, and that then these fragments can be assigned to their correct chromosome. And if there was an imbalance in the amount of chromosomal material associated with the various chromosomes, then that would be how we detect or screen for Down syndrome. There have been now many studies that have looked at the use of cell-free DNA in detecting chromosomal problems. This was Melissa's study, one of the earliest ones that we were participated in at Eastern Virginia Medical School. And here we are for trisomy 21, 100% sensitivity, 100% specificity. Very good for trisomy 18 and 13, but not quite as good. But these are all in what we call high-risk pregnancies, that is, pregnancies in which they were already at increased risk, so a higher prevalence data patient group. And 5 years after the ACOG talked about first trimester screening, here in December 2012, the ACOG opinion on non-invasive testing, in which they said that it was a very effective technique for young detection. The patient choice, at least at that time, they tried to emphasize always on singleton high-risk pregnancies, and they also emphasized the need for follow-up diagnostic testing. There have now been many studies that are similar in high-risk patients. So we can take for trisomy 21, there were 24 studies, detection rate 98%. For trisomy 18, detection rate 95%. For trisomy 13, detection rate of 91%. But also want to emphasize the selection rate, 1%, 0.1%, in order to achieve these various Down syndrome detection rates. And so we did it. We started off way down here. We moved up to about here. We then came to here. And finally, through NIPT, non-invasive prenatal testing, we achieved almost 100% detection at a very low false positive rate. Now, there are cases in which there can be false positives in the cell-free DNA, and this can be in cases of confined placental mosaicism, situations in which there was a twin pregnancy or a vanishing twin that may have had an abnormal karyotype, maternal mosaicism, maternal cancers have been detected by cell-free DNA, copy number variations, transplant recipients, people who've had a recent blood transfusion. All these things can cause false positive results for cell-free DNAs. Now, I want to take a couple minutes to talk to you about our experience at EVMS with NIPT, and this was a review of about 6 years of data. We had about over 7,000 NIPTs. By now, we've got about 15,000 NIPTs. The vast majority of cases were in high-risk situations. And what were our results? For trisomy 21, we had 109 positives, and they were all true positive with a positive predictive value of 100%. And not quite as good with some of the others, but still very effective. Now let's talk about the effect that NIPT has had on other screening and diagnostic tests. So this is a table. It looks at our experience with with first trimester screens over the years. And the real heyday for first trimester screening was 2009, 2010, where we were doing about 1,800 first trimester screens a year in our practice. But with the introduction of NIPT, you can see how that has really affected things, and that in 2018, we only did 280 or so first trimester screens, down from over 1,800 a few years earlier. How about amniocentesis? In our program, we were doing 700 to 800 amniocentesis a year from the mid-1990s through 2005. But with first trimester screening, you can see the dramatic drop. And with NIPT, our numbers dropped even lower. So that in 2018, we only did 103 amniocentesis for the entire year. And CVS, similarly, we see that, well, with first trimester screening, our CVS numbers started going up because we were doing first trimester screening. But then with the introduction of NIPT, our numbers dropped again, and we were doing only 35 CVS in that year. And this is a more updated table. We talk about 2017, 2018, 2019, 2020, 2021. In terms of CVS, 25 to 30 a year. Amniocentesis, still about 100 per year. And of course, that included some amnios for fetal lung maturity or for Rh disease or other indications. And nuchal translucency, and remember, at one point we were doing 1,800, almost 2,000 nuchal translucencies a year. In the last fiscal year, we did 52. Now, that's not the end of the line, because there are additional techniques that have come into play. What's referred to as DANSER, or digital analysis of selected region. And this is a more directed analysis using cell-free DNA, and it is 10 times more efficient. And because it's so much more efficient, the cost has dropped dramatically in the United States. At one point, NIPT cost $1,200, and then it slowly decreased and decreased. $400 more recently, there's $200, and on our Black Friday sales, there's now $99 NIPTs. And because it's become significantly less expensive, the overall screening program has become less expensive, and now it's available to both low and high risk patients. So here's this slide that we saw before. Now we've pushed off all the first trimester screening. We pushed all the second trimester screening off to the side, and NIPT is really the way to go. Now, much of the data that came out initially from NIPT was related to high-risk populations, women over 35, women who had other screening tests that were positive. The question was, how effective would it be in a lower-risk population? And this is a study that was published in the New England Journal of Medicine in 2015, 15,000 patients from 35 international centers on average risk patients. And the bottom line is comparing the sensitivity between NIPT and first trimester screening. 100% sensitivity, 79% sensitivity. False positive rate, 0.06 compared to 5.4. Positive predictive value, 81% for NIPT, 3% for first trimester screening. Now, you might say at this point, well, why not do universal carrier screening? And one of the questions came up is, well, in a lower prevalence population, there will be a lower positive predictive value and a higher false positive rate than in a higher prevalence population. That's true. What about the cost? What about the availability of counseling? Will people terminate pregnancies prior to diagnostic testing? What if we find a variance of unknown significance? And of course, there's always a concern about the potential for using this, a first trimester test, for sex selection and people terminating pregnancies if they didn't like the sex of the fetus. Well, let's look at this issue of positive predictive value. And I apologize for talking kind of fast, but I know that Dr. Abu Hamid is going to be speaking shortly, and he's an excellent speaker. So let's talk about the positive predictive value of NIPT. And we've said that it has a sensitivity of 99% and a false positive rate of 0.1%. Now, in the older women, where the prevalence of Down syndrome is higher, we can see the positive predictive value is 98, 93%. But in the lower prevalence populations, we can see that the positive predictive value drops pretty significantly. Now, some people could say, well, that's a criticism of NIPT. But let's compare NIPT with first trimester screening or second trimester screening. And look in the lower populations, the lower prevalence population where NIPT has a positive predictive value of 57, 47%, 40%. First trimester screening or AFP screening has a positive predictive value of 1 or 2%. So that even in the lower prevalence population, NIPT is a significantly better screening test. And now there are online calculators that are available that will tell you the positive or negative predictive value of NIPT at any maternal age. What about the cost? Some people said that the cost of an NIPT screening program would be prohibitive. So I did a cost analysis using some numbers that are common in the United States. And although this is a busy table, I want to explain to you what it shows. So we talked about using advanced maternal age, or just history, as a screening test. The cost of asking those questions is 0, but that led to, in a 1 million live births. Now, in the United States, we have 4 million live births, so we have to keep this in mind. So using AMA alone led to 180,000 invasive procedures with a total cost of $450 million. In this million patients, there was 1,428 cases of Down syndrome, and this screening technique detected 33% of the at-risk patients. So we missed 952 cases, and we lost 360 fetuses because of the loss rate after 180,000 invasive procedures. If we look at these other screening tests, you know, we talked already about detection rates and things, and you can see the cost, the total cost of the programs was going up and up and up. When we used the sequential screening, at $1.13 billion for 1 million live births, okay? But of course, our detection rate was getting better, and the number of losses were getting lower because we were doing a lot less invasive procedures. But with the introduction of NIPT, initially with massively parallel shotgun sequencing at $1,500 a shot, it was the most expensive of the screening tests, but it had the highest detection rate, the lowest number of misdiagnoses, and lowest number of losses because we were doing so many fewer procedures. In 2021, when NIPT cost about $200, then the cost of the screening is $200 million for 1 million cases. We're doing only about 5,000 invasive procedures. So our total cost of this program is $212 million compared to all these others. So from a cost perspective, as well as the efficiency and effectiveness of screening, NIPT is clearly the way to go. We only have a moment left to go, so I'll try to summarize with what should we do in 2021? Well, really the question is, what's the question, okay? Because at least in the United States, we have many different ideas, many patients have different ideas of what they want. So if the question is, does the fetus have Down syndrome? Then what I would recommend is NIPT and a morphology scan. Now, soft markers such as echogenic intracardiac focus, choroid plexus cyst, these are all normal variants and should not really be used as a screening technique any longer. If the question is, does the fetus have a birth defect, and that's all the patient is interested in, then she should have an early morphology scan and a follow-up scan a little bit later. If the patient wants to know, is my fetus completely healthy? That is, that she wants to know everything or as much as possible, then she's still going to need an invasive diagnostic test using microarray and serial ultrasound scans. If the question is the fetus has a congenital abnormality, what should we do with that patient? Then the answer is genetic counseling and an invasive procedure if she desires. And finally, we have a large population of patients that say, I'm happy with any outcome and I will deal with any situation as it arises, and pregnancy termination is not an option for me. Then she probably shouldn't have any of these screening tests and should just have what we call a morphology scan. So in conclusion, Down syndrome screening based on maternal age alone is no longer justified. All patients high and low risk for aneuploidy should be offered screening for aneuploidies in the most cost-effective manner, and at this time it appears to be NIPT. All high-risk patients should also be offered formal genetic counseling to review all their options. The number of patients having invasive diagnostic tests have decreased dramatically, while the yield per diagnostic test has increased remarkably. NIPT should still be considered a screening rather than a diagnostic test, but it has the highest sensitivity with the lowest false positive rate of any screening strategy and is most cost effective. And an early morphology scan at 12 to 14 weeks also remains an important screening tool for us. And with that, I want to thank you for your attention. And I was talking to Professor Ivan earlier, and I hope that my family will come to visit you in Hungary at sometime over our summer holidays once we get past all our COVID issues. And I'd be happy to take any questions at this time.
Thank you very much, Steve. That was very nice. This is David Archer back again, and we have a few moments. I'd like to give us 4 minutes for questions before the next speak. If you will just raise your hand, we will do our best to acknowledge you. The raise your hand button is at the very top of your screen. I don't currently see any raised hands. I think the biggest question I would say is to Dr. Warsoff is how prevalent is this screening test outside the United States?
Well, you know, in many countries that have national health insurance programs, they are moving more and more to NIPT, especially as the cost of NIPT has dropped dramatically. And you know, from that cost analysis that I showed you, you know, when NIPT was $1,500 a shot, and you know, the cost was actually more for screening with NIPT, but it was much more effective. But now, as the cost of NIPT has dropped dramatically, it really seems to be cost effective and effective in every way. And I think that more and more countries are moving towards that. But you know, I don't know for sure. Perhaps our colleagues from Hungary could tell us what the situation is there.
I'm sure that's true. And now I'd like to move Dr. Bettelheim. Professor Bettelheim, you had your hand up.
Yes, good afternoon. In Austria, the situation is that we have two classes of patients. The well-to-do people, they do very often NIPT, and the women which are under normal social security system, they have less frequent NIPT because it's still relatively expensive. But there are many companies with competition so that the price is going, it becomes cheaper every month. In our university clinic, we have a special procedure. At first, we do an ultrasound between 11 and 14th week, first trimester screening, where we are able to divide between 3 risk groups: low risk, intermediate risk, and high risk. In the intermediate risk group, the patients which are booked for delivery in our clinic get the NIPT for free. Those in the low risk group, they have to go to private offices to get NIPT, and the high risk group of patients is able to get for free invasive testing by chorionic villus sampling or by amniocentesis. We never do NIPT alone, always after ultrasound examinations.
Thank you very much. Dr. Bartzai had a question.
Well, could I just make a comment?
Yes.
In many European countries, they fought very hard to get national health insurance programs to do first trimester screening and nuchal translucency screening. And once that was done, it's kind of difficult to back off and say, well, actually, we don't need it that much, and that this NIPT is a even better technique. But you know, it's hard to put bureaucracy forward. And maybe this is why in the United States we move very quickly to NIPT because it's all based on cost rather than bureaucracy. I'm sorry.
Oh, that's quite all right, Steve. This last question is from Dr. Bartfai. Dr. Bartfai?
First of all, congratulations. It was a very nice, comprehensive presentation. And you are welcome in Hungary. And if you come to Hungary, even the summertime is not best for scientific meetings. Perhaps we can organize something for you to deliver a presentation, a lecture here in Szeged. My short question is, you mentioned in your presentation that the false positive rate using the cell-free DNA was 0 when you screened the 21 trisomy, but 18 trisomy and the other was some false positive rate. Why is it more difficult to screen the 18 and the other trisomy than the 21 trisomy?
So that's a wonderful question, and it all has to do with the algorithms in which they do the cell-free DNA counting, and it has to do with the sequencing. And I'm sorry if I cannot give you a better technical answer to that question, but it's the companies that are working on this have been improving their algorithms so that they try to get better and better screening rates.
Okay, thank you.
Thank you, Steve. I have one last question from Dr. Malik. If the NIPT is normal and the morphology scan shows cardiac disease, do you advise an amniocentesis?
So that brings up the issue about a normal NIPT and a chromosomal, fetal structural abnormality. And in order to, there are many other problems like 22q minus that is frequently seen. So we would encourage somebody in that situation to have or any fetal anomaly that we're interested in finding out as much as possible, that they should have an invasive diagnostic testing, and not just to obtain a karyotype, but to do a microarray analysis of the fetal DNA.
Thank you very much, and thank you again, Steve, for that very interesting presentation. I'd like to switch now and introduce to you Dr. Alfred Abu-Hamid. Dr. Abu-Hamid currently is serving as the interim president, provost, and dean, as well as professor and chair of the Department of Obstetrics and Gynecology at Eastern Virginia Medical School here in Norfolk, Virginia. He is the past president of the Society for Maternal Fetal Medicine, the Society for Ultrasound and Medical Education, the Perinatal Quality Control Forum, and the American Institute of Ultrasound and Medicine. He's published more than 180 peer-reviewed manuscripts, authored 6 textbooks in fetal echocardiogram, ultrasound and obstetrics and gynecology, first trimester ultrasound and office procedures, and has received numerous national and international awards. He is well known internationally for his work in ultrasound, perinatal diagnosis, fetal echocardiogram, global outreach, and patient safety. Specifically, today I've asked him to talk about ultrasound diagnosis of adnexal masses because for the generalist, I find this one of the most intriguing and important things that has come out of ultrasound in medicine, and I'm delighted to have Dr. Abu-Hamid with us today. Dr. Abu-Hamid, the podium is yours.
Thank you, David. I'm asking Steve to unshare so I can be able to share. Let's see. So are you able to see my screen or no?
Not yet, Alfred. Steve, did you block yours out?
So it's not giving me the option to share when I say the entire screen. Okay, now it is. Okay, hold on. share. How about now? Can you see the
Yes.
presentation
Yes,
right?
it's working.
Yes.
Okay. All right. Just sharing your screen. Hide this. Okay. Thank you.
My name is Alfred Abu Hamid, and I'm going to, during this presentation, present you with some adnexal masses with the hope of providing you with important sonographic clues to help diagnose benign lesions and also to differentiate benign from malignant adnexal pathology. I'll strongly recommend this free online open access ebook. Within it, there is a lot of description of what I will be talking about, especially in the identification of select benign adnexal pathology. So I'll start with a case with the several case presentations. Here's a 25-year-old referred with the left pelvic pain, and that's an ultrasound of the left adnexum. So if you look at this adnexal mass, I think you should recognize that this is a hemorrhagic cyst. And I say that because this is a lacy reticular pattern that you see right here. Appears like a solid mass, but there's absolutely no shadowing beyond. There's a capsule that is seen that is well formed throughout the mass itself. If you add color Doppler, and you should not see any vascular signals within the content of this mass. This is an artifact here and here and here. That's because it's a blood clot and should absolutely have no blood vessels in it. And that's a very important diagnostic criteria that you should employ in assessing adnexal masses. When you do this, keep in mind that your velocity should be as low as possible. Velocity scale, I would recommend somewhere between 5 to 10 centimeters per second. Your gain should be set up at high, and your filter should be set up as low as possible. Remember, these are important color Doppler features that really helps you evaluate the presence of blood flow within adnexal masses. So clearly, this is a hemorrhagic cyst. If you follow this patient up, you will see that the clot starts to retract over time, and you'll have a fluid level here that is developing. Again, no blood flow within the content of this hemorrhagic cyst. And these are the characteristics that I have mentioned to you. Now, an important feature also, as the clot retracts more and more, as you see in this hemorrhagic cyst, the clot tends to jiggle when you probe the cyst with the transducer. And what is important to see also here is that the borders of this clot that is retracting is smooth, as you see all the way around. Typically, it's attached to the wall in one or two foci. Also, what is really important, if you look around the capsule, there are no other papillary projections. So the clot tends to retract to one location, not to multiple locations within the mass itself. Compare that previous classic hemorrhagic cyst to this ultrasound here, where you see ragged edges of what looks like a papillary projection, not really a clot, and another focus and maybe a third small focus here. And I'll come to this case later on in the presentation. So that's clearly not a hemorrhagic cyst here, and that is something that should be concerning for neoplastic changes. Here's another case, 28 years old, 11 weeks pregnant, patient is totally asymptomatic. Here's the left adnexa. You have a mass that's 11 centimeters in length. So what would you do? Color Doppler, certainly always helpful in assessing of adnexal masses. You see there is blood flow within these thick septations, and this blood flow has low impedance. There's a lot of diastolic flow with an RI of 0.38. Typically, the cutoff that has been used traditionally in the literature to assess postmenopausal patients is somewhere around 0.5. So anything below 0.5 is low impedance, and these are the concerning indices. Again, more relevant in postmenopausal patients than premenopausal patients. So this is concerning enough that we recommended the patient to go to surgery in the early second trimester of pregnancy, and this was an adenocarcinoma and a borderline tumor. So what are the characteristics of borderline and malignant adnexal masses? Again, this is from the ebook. Irregularities in the capsule and content, thick septations, solid content, papillary projections, really, really important in the presence of vascularity. Here's another case, 24 years old, presented with pain in the right lower quadrant. So more imaging. Again, this is for orientation sake. Here's the uterus, the adnexal mass, and here's the ovary. Beta ICG level was 22. So what are your thoughts when you see an adnexal mass that is symptomatic in a patient with chronic pain that is present between the uterus and the ovary, has the characteristic of what looks like an ectopic? If you add color Doppler, you see the extensive peripheral vascular blood flow. Again, this should be suspicious for chronic ectopic. This patient went to the OR, and indeed, this was a chronic ectopic pregnancy. So I wanted to share some features. This is not a common adnexal pathology that you would encounter. Here's another classic case at 38 years old, asymptomatic, presenting with the left adnexa. So if you look at this adnexal mass, you see, first of all, there's normal ovarian tissue surrounding this mass. This is a very good sign. If you see normal ovarian tissue, the studies have shown that these are almost always benign etiology. You see there are some what looks like echogenic structures or nodules within this content here that do not really shadow. So this is the fat emulsion within the cystic dermoid or the cystic teratoma. So that's a classic feature of cystic teratoma, to have this white echogenic content within that is typically the fat that is present within the content itself. And certainly this was a cystic dermoid. Characteristics, they may have a solid center that typically shadows. So they could be complex tumors. They have this thin linear strands that is characteristic when you see them, related to the dispersion of the ultrasound beam on the hair within typically the Rokitansky nodule. They tend to be high in the pelvis. So usually you should scan transabdominally also to make sure you don't miss them. Absolutely in benign dermoid, you should not have any blood vessels, again, on color Doppler with these indices here. All these are dermoids. You see they have different etiologies, different appearances. This is the linear strands that I was talking about, and that's the Rokitansky nodule here, here, and here, with some shadowing, as you see. So these linear strands are really important and helps you in make the diagnosis on many occasions. This was a large adnexal mass in a pregnant patient with shadowing from two locations, we believe related to the presence of teeth within this large dermoid. Again, note that I am at 11 centimeters per second here, absolutely no blood flow within the content of this dermoid or teratoma. Another case, 28 years old, pregnant at 31 weeks. This is the left adnexa. So if you look at this case, at this adnexa, you will see that there is significant solid content within this mass. There's also blood flow within this solid content. And here's another angle to show you how extensive that solid content and how quite vascular this content is. So patient is 31 weeks, concerning enough that this mass needs to come out. No need for intervention at this time, probably could wait until closer to term. Color Doppler pulse, the spectral Doppler confirms the presence of vascularity within. Went to the OR, and this was an immature teratoma with neuronal elements. Certainly would require assessment, evaluation, and follow-up afterwards. But the ultrasound features are suggestive of malignancy here, the presence of solid content with vascularities within a complex mass. He's a 62-year-old referred to assess a left adnexa. So here's the left ovary, what looks like the left ovary here. Let me show you some additional features. Color Doppler shows that there is vascularity within this part, this solid content here. And you can see the spectral Doppler waveform right here. So this patient is 62 years old. Are you concerned? Here's the right ovary. Appears to be normal. concerned enough that we recommended this patient to go to the OR. There certainly are extensive vascularity for a patient that is 62 years old, postmenopausal. The borders are not that ragged though, so I was kind of not really concerned that this could be a malignancy, but certainly given the sonographic features would require removal. And this was a mature teratoma with struma ovari in a patient that's 62 years old. How about this 31 years old at 12 weeks pregnant? And here's an adnexal mass. Let's look at this and describe what we see, because this is really important to understand how critical it is to evaluate these adnexal masses very closely. So you have a complex mass. There's a solid component, looks like a papillary projection. Look at the borders of this papillary projection. Look how ragged this edge is. That is not a clot that is retracting. This is one. Two, there is blood flow. Again, on low velocity scale, that's a real vascular signal inside. And three, as important, if you look very closely here, there's another small focus of a small papillary projection that is growing here. We were concerned enough that we recommended that this patient should go to the operating room during pregnancy in the second trimester, and then this was after removal and immature teratoma. Again, classic features to remember: presence of papillary projections, blood flow on color Doppler, and so forth. How about this 34 years old, referred with a large left pelvic mass, history of infertility? You should look at this ultrasound image and make the diagnosis of endometrioma. This is a classic for endometrioma. It's a ground glass appearance that is uniform, a well-seen capsule all the way around, absolutely no shadowing from the mass itself, and color Doppler showing you no vascular signals at all. There is no, this is all blood. They should not see any vessels within this mass itself. And look, I'm at 5 centimeters per second. So that is really, really, I'm looking for capillary flow in here. Here's another angle to this, and there's maybe a follicle that is growing in the side from the capsular tissue here. Again, this is a classic left endometrioma. Excellent sound transmission. The characteristic of endometrioma is homogeneous ground glass appearance, typically unilocular. Sometimes they may have a septation in them, but sometimes they have a calcific stipplings, hyperechoic foci within them. Clearly, extremely important, no vascular signals on low velocity color Doppler settings. Here's another large endometrioma. Look at the swirling that you see, but if you look very closely, there's no acoustic streaming. You don't see the particles within the endometrioma move around here. Compare this classic endometrioma, here's the uterus right here, with this mass right here. You see the acoustic streaming when you slow down and take a look. This is very uncharacteristic of endometrioma. This is more common in mucinous cyst adenomas and mucinous content within adnexal masses. So this is a mucinous cyst adenoma. Endometriomas have acoustic streaming, but certainly not as much as you see right here. Here's another case that was referred to me. A 42-year-old had a cesarean section in 2015. She presented in 2018 with left anterior abdominal pain. Now, we were able to reproduce the pain with transducer pressure, and in evaluating her fascia, we are able to see this, what looks like an endometriotic nodule in the middle of her fascia right here that appears to be quite tender. Color Doppler shows there is a significant vascularity that's coming into this. So we have had some discussions with the referring physician, and here's the spectral Doppler of this vessel that is in the middle of what looks like an endometriotic nodule. We decided that this is an endometriosis in the abdominal wall fascia. The day of the surgery that was planned, we placed the needle inside this nodule and injected diluted methylene blue to allow the surgeon to identify where the nodule is within the fascia and excite it. And after excision, the pain was completely removed, and the patient was asymptomatic post-surgical resection. So this was an endometriosis in the abdominal wall fascia. 45 years old, gravida 4, asymptomatic, so this is not a pregnant patient, presenting with the right adnexal mass. So I'm going to have you look at this with color Doppler. I don't see a lot of blood flow in here, but the mass is unusual in shape. Here's another look at this. Patient is totally asymptomatic. Certainly recommended that this mass be removed given its size, given the way it looks. And this was a low-grade mucinous cystadenocarcinoma of the right ovary. I was surprised because I could not detect any vascular flow within, but certainly the content, the appearance was concerning enough that it needed to be removed. And it's not pathognomonic of any of the classic benign adnexal masses, such as endometriomas, dermoids, and things like that. So this was an unusual case, and I wanted to share the findings with you. Here's a 41-year-old referred with right-sided fullness. This is a large mass on exam. So what you see here, you see an adnexal mass. You see there's a lot of solid content inside with ragged edges. There's a lot of vascularity within, and spectral Doppler shows some abnormal vessels with a RI of 0.41. Clearly, the patient needs to go to the operating room. I was highly suspicious that this was going to be an advanced stage of cancer. This came back as borderline mucinous tumor. The reason I'm sharing this case with you is that I think it's with experience, you should be able to differentiate what is benign and what is malignant, or at least what you could be conservatively managed and what needs to go to the operating room. I think the ability to differentiate a borderline from an invasive tumor is very difficult in my experience on ultrasound. There are some masses where I clearly, like this one, suspected were going to be an advanced stage of cancer, came back as borderline mucinous tumors, and vice versa. The 32-year-old, the 13 weeks gestation, referred post-acute pain in the ED with right-sided mass. So I got this image from the patient. I took a picture of this. This image was given to the patient in the operating room. She presented with acute pain to our main hospital here at Central Norfolk General Hospital, was evaluated for several hours. The pain had subsided during her admission. She was discharged and asked to come and see me. This was on a weekend, to come and see me on Monday. And this was the ultrasound that she had done in the emergency room. And you could see the mass is 16 by 8 centimeters. Here's the ultrasound on the day that I saw her. You see the fetus here at 13 weeks. And this is the adnexal mass on transvaginal. Get better images for you. And here's the mass itself. So if you look at this, there's a significant solid component within it, has ragged edges all the way around. Certainly color Doppler shows that this mass is highly vascularized. In looking further into the patient's history, here's the spectral Doppler showing clearly significant flow in diastole with a PI of 0.27. And here's a 3D rendering of the vascularity of this mass. So clearly this patient needs to have this mass removed. In looking further into the patient's history, her MSAFP was 30 multiples of the median. So you immediately think about germ cell tumors, a solid tumor that is highly vascularized in a patient. And I think what happened in the emergency room is that the cyst has ruptured, and that's why there was fluid content within the cyst, and now I'm just seeing the solid component that is still there. So this was a mixed germ cell tumor with yolk sac elements. Here's a bit of an unusual case that I wanted to share with you. A 51-year-old referred for evaluation of a pelvic mass. So here you look at the cervix. There's this mass laterally to the cervix. You see part of the uterus on this side. The mass is clearly echogenic. And you see right here, not a lot of shadowing. The location of it and the size of it was suggestive to us that this could be a fibroid that has lipase degeneration in it, especially with the significant brightness that this mass has. The location is unusual in the cervix, but certainly you could see some vascularity within. We recommended, given the patient's age and the findings on ultrasound, for the patient to undergo removal. And here's the spectral Doppler findings. And this was a lipoleiomyoma. So again, lipoleiomyomas are myomas that have lipase degeneration. They don't tend to shadow as much as standard or traditional leiomyomas, but they appear quite bright and echogenic, and usually are benign. You could follow them up if you know, but this was an unusual location and the patient's age and the presence of a bit more vascularity than I would extend in a fibroid, where we recommended surgical removal. All right, the 31-year-old, 35 weeks pregnant, referred for evaluation of adnexal masses. So here's the right ovary on grayscale, and here's the right ovary on color Doppler. And you can see this is, each one is 1 centimeter, so this is about 6 to 7 centimeters. Certainly there is significant vascularity within. So here's the left ovary. Here's the left ovary on grayscale, 7 centimeters in length. And again, here's the clip of the left ovary showing you the size of the left ovary. So what should you do? Should you take these adnexal, bilateral adnexal masses out? Should be careful, because you should not. These are classic for luteomas. You can see the size of these. They still maintain this ovoid shape of the ovary. They appear like solid masses. They appear uniform. So we decided not to do anything. And here's the follow-up 2 months postpartum. Here's the left ovary, and here's the right ovary. And they went back to normal in size. So we suspect these were luteomas in pregnancy that have regressed postpartum. So be careful. There are some adnexal masses that you have to be careful not to rush to surgery and recognize the pathognomonic signs of what this could be. Ironically, around the same time, and I'll come back to that actually in another case, but let me show you this case. This is a 33-year-old, 15 weeks pregnant, referred for evaluation of left adnexal mass. So if you look at this left ovary, you see that this papillary projection is irregular in shape. This does not look to me like a hemorrhagic corpus luteum or a hemorrhagic cyst. Color Doppler shows some blood flow within. Again, here you see on real time. I'm concerned in looking at this that this could be a borderline tumor, a serous cystadenocarcinoma. Recommended for the patient to have this removed, and this was a luteoma. So you could see the difference between the previous luteomas that I've showed you that have classic description of an enlarged, uniform, ovoid shaped ovaries with solid content, and with this particular case that looks very different, looks concerning for a malignancy. I thought that would be helpful to show you the difference between the two. This is an unusual presentation of a luteoma, but I wanted to show you the case to reflect on that. 42-year-old left adnexal mass, pain in the left lower quadrant. So you can see it's a solid mass, extensive vascularity. Patient is not pregnant. Here's some spectral Doppler, again, borderline RI. Certainly would need to go to the operating room given what we see. And this was a carcinoid tumor in the appendix with metastasis to the left ovary. Again, unusual case, but again, solid tumor in the ovary in a 42-year-old that is vascularized is significant enough to recommend surgery. All right, the 19-year-old, gravida 1 at 14 weeks, referred for evaluation of adnexal mass. So you can see here what I'm seeing here. This is one ovary, and that's the other ovary here that comes into play. So is this a hemorrhagic cyst? Clearly not. Multiple foci with papillary projections, irregular borders. And here you see the mass that's in the cul-de-sac is highly vascular. And again, you could see here the longitudinal view and the axial view. And here again, look at this vascularity within this papillary projection muscle. This is clearly highly concerning. This patient needs to go to the operating room to have this removed. And here's a 3D rendering of the vascularity of this papillary projection. And here's the left ovary on this patient. You could see there is another mass within the left ovary. It's a little bit ragged, but it is not a resolving corpus luteum because there's some blood flow within. So quite concerning too. And here you see on color Doppler that this is clearly not a hemorrhagic cyst. So we recommended for the patient to go to the operating room. She went on November 2013. So this was a case from a while back. And this was a stage 1A serous borderline tumor of the right ovary. So when I looked at the pathology report, and I have a system in place to follow up on those patients and see, I was surprised I did not see any pathology on the left ovary. So I had called the referring physician and I've asked for the patient to come back and see us because I was concerned that I could not see pathology of the left ovary or at least a biopsy of what we were looking at. So the patient came back in April 2014, and this is the left adnexa now. Compare it to what it looked in 2013 to April 2014. This is what I've shown you in the beginning of the presentation after I presented the case with the hemorrhagic cyst. Very concerning to me. Again, this looks a significant expansion from what I have seen before. I asked for the patient to go back to the operating room, and you could see how vascular these lesions are. And this was a serous borderline tumor of the left ovary. So whether this would have progressed to a metastatic cancer, it's hard to see, but you could see significant progression between 2013 and 2014. Here's another case, a 24-year-old referred for evaluation of right adnexal mass and metrorrhagia. I'm going to go quickly. I'm going to share with you a couple of cases. Right adnexa, again, a solid large mass with some shadowing, which is really important for the differential diagnosis, but vascular. Here's the other side, looks normal. So what was this? Fibrothecoma of the right ovary. The reason I mentioned this shadowing was significant because when you see shadowing like this within a mass, you should think about a fibroid, about the fibroma of the ovary, because that's how it presents. And let me show you this other case, a 29 years old, referred to assess the right ovary. Here's the right ovary right here. There appears to be a mass coming from the right ovary. Here's another view. Again, look at the shadowing here. That is what's called Venetian blind shadowing that is characteristic of fibroids, uterine fibroids. When we use the transducer as an extension of your exam to see does this mass attach to the ovary or is separate, you see that it's attached to the ovary. Look at the shadowing pattern. We suspected this was an ovarian fibroma. Patient went to the operating room and this was an ovarian fibroma. Again, shadowing pattern, very, very characteristic for that. When you see adnexal masses, use your probe to gently push up to see, here's a fibroid that is clearly separate from the ovary. The ovary is moving separate than the fibroid. You see the shadowing from the fibroid. Again, that is a fibroid in the adnexal region rather than an ovarian fibroma. So in putting all these together, hopefully I have shared with you some key points to help learn what the normal sonographic characteristics of benign adnexal masses are. Use color Doppler is essential to the evaluation of adnexal masses. Make sure you are in low velocity, low filter, and high gain setting to make sure you are not missing capillary flow that exists. The transvaginal probe should be an extension to you to evaluate the source of pain or the origin of the masses, or you can probe to see if there's any, if you are if the mass is attached to the ovary or separate from the ovary. Presence of thick septations and papillary projections are concerning. Remember, if you see those in pregnancy, especially in the window where it is quite safe to go to the OR, recommend that. When unclear, a follow-up ultrasound in 1 to 3 months is helpful to assess for interval changes. Thank you very much for your attention.
Thank you very much, Dr. Al-Muhammad. Dr. Al-Muhammad should be joining us back in just a second or two after that.
I am here, David, so thank you.
Thank you very much, Alfred. We're open for any questions. If you'd like to raise your hand, that would be helpful. Or if you'd like to just come online and tell me that you have a question. I'm also taking anything, nothing in the chat box. Alfred, you showed a separate number of adnexal masses that were concerning during pregnancy. How frequently do you think these occur, and how are they usually diagnosed? From symptoms or just by incidental finding?
Most are by incidental findings, David, that they are seen during the first trimester ultrasound at the referring physician's office. And they are sent to me for further evaluation. Because of the nature of our referral unit, we tend to see a lot of them. But in general, it's rare. I think 1 to 5% of adnexal masses in pregnancy will be malignant. So usually the incidence is lower, but because of the nature of our practice, we tend to see a lot of them.
Dr. Petru.
Yes, hi.
Hello.
I want to congratulate you. It was very comprehensive and very clear. It would be very useful for all the residents to see this. But I have a short comment about this. I used to say that to my students and to my residents that any breast and ovarian tumor, which is not vanishing in a short time, it must be considered potentially malignant till we cannot prove the contrary. And the proof of contrary is the histopathology. So I think in almost any tumors, endometriomas, but almost malignant and borderlands. And the first step is to have a surgery and to refer to the pathologist. So and I used to say that if it's a benign tumor, everybody's happy. So thank you again. It was very, very, very interesting and useful.
Thank you. Let me provide a comment on this. I respectfully disagree. I think there are a lot of adnexal masses that we can follow for years that look benign and don't have the malignant characteristics. And you don't have to expose the patients to surgery for things that are benign. And we know there's a very, very low chance of transformation. So for instance, a dermoid cystic teratoma or a dermoid mass that has no blood flow in it, the chance of malignant transformation is exceedingly small. And if you follow them up every 6 months and they don't change in appearance and there's no blood flow, you can conservatively manage them. Endometriomas are a little bit different. They have about 5% chance of transformation into malignancy. And those, you certainly need to consider taking them out depending on the risk of the patient and the age of the patient. But there are a long list of adnexal masses that I have been following for years on patients that come to see me every 6 months. And in the greatest majority of them, there's really no need for surgical intervention.
Thank you, Alfred.
Okay.
I have a question from Dr. Anna Mitrovic. She wants to know if you use calcium CA-125, HE4, and the Roma index for evaluation of adnexal masses.
So the CA-125, typically, you know, I'm an obstetrician, so I'm not by training a gynecologist, but my specialty is imaging. So typically those patients come to me with CA-125 done outside of pregnancy. So certainly it's a very important element. And the other tumor markers are really based on what you suspect and what you see. Certainly in younger population, the tumor markers for the germ cell tumors become really important in that setting. With regards to grading, the IOTA criteria or others that exist, I think they can be very helpful for those who don't have a lot of expertise in imaging and adnexal masses imaging. Studies have shown that as you accumulate expertise and you become an expert in adnexal imaging, your performance is very similar to those grading systems. But the grading systems could be very helpful, certainly, to add to what you are seeing and objectively try to characterize the tumor.
Thank you for that answer. Are there any more questions? We're open for questions. Dr. Mohammed is certainly available to us for a few more minutes. If you don't feel like asking the question, put something into the chat. I'm monitoring the chat function right now. We will give you certainly another few moments. Must be the dinner hour in Romania, Serbia, and Hungary. That's the issue. The audience is very quiet tonight. All right, I don't see any more chats. I don't see any more hands. Alfred, thank you very much. It was a very interesting presentation. I much appreciated it.
Thank you.
Thank you. Let you off the hook. Ladies and gentlemen, thank you for attending. I hope you've had an enjoyable time at this presentation. We certainly feel like this is part and parcel of the entire program that's going to be held for the Diczfalusy Foundation over the succeeding several months. And I look forward to having you come back for the next program and the remainder of the program throughout the year. And I want to thank the Diczfalusy Foundation for the organization. And particularly, I want to thank Dr. DeBosa for his help in making sure that this presentation went smoothly. I hope you have a good night. In the United States, tomorrow is Thanksgiving. We should all be thanksgiving for being here and with our friends and with our colleagues. And I wish you well in the future. Goodbye.
David.
Yes.
Thank you very much for your help to organize such a good meeting and for your continuous support towards the Diczfalusy Foundation. And I am looking forward to seeing the next meeting in which you will be again the host.
George, I'm delighted to do it. I am delighted that we're doing this virtually. I'm sorry that it's not in person, but I certainly think that the opportunity exists for us to reach an extended audience that we may not have been able to gotten together based on travel restrictions, COVID problems, et cetera, et cetera. So I think it's a great opportunity for us all, and I hope we continue to do this.
So thank you again. I am happy to see you in a good shape, and I hope it will be continue like this.
I tell you, George, so do I. I'm looking forward to a couple more years of good health. I'm hoping that we all have that. Good health and prosperity go hand in hand. And I was amazed at the number of members of the foundation board who are on today, and I wish you all a very, very happy season greetings for the next month or so, and I hope everything works out for you.
Okay. Good night,
Southwestern
for the
United
Europeans
States.
And greetings for the Americans.
Yes, as we say in Southwest US, adios. Goodbye.
Goodbye.
Bye. Okay.
They leave the meeting.
Yeah.